Hello and welcome everyone to today's Facebook Live event. We'll be covering advanced imaging, and it's my pleasure to have Dr. Danielle Kuftinec. She is the Medical Director of Global Medical Affairs at Lantheus, joining us today. Dr. Kuftinec joined Lantheus in March of 2022. And she serves as a board-certified urologist in clinical practice for the past 15 years. She's a member of the American Urological Association. She received her medical degree from Tufts University and completed residencies at Boston University and its affiliated Boston Medical Center, Boston Children's, and VA Boston Healthcare Hospitals. She lives in Carlisle, Massachusetts with her husband and 2 sons. Dr. Kuftinec, thank you for joining us today for this important discussion.
Thanks so much, Jeremy, and thank you for having me. It is really my pleasure and honor to discuss advanced imaging today with the audience.
Well, let's get started. First, let's start with the basics, right? We want everyone to have a good understanding when they walk away today from what we're talking about when we're talking about advanced imaging. So what is a PSMA PET image?
Right. So I completely agree. We need to sort of get all the definitions as much as possible under our belts here, because we do use a lot of acronyms in medicine, in diagnostics, and pharmacology. So what is a PSMA PET image? So a prostate-specific membrane antigen positron emission tomography, or PET scan, is an imaging test that's used to detect prostate cancer throughout the body. And it uses a radioactive substance that targets a protein called PSMA, or prostate-specific membrane antigen, which is overexpressed by prostate cancer cells. And this makes it a very accurate way to detect prostate cancer. It's actually more accurate than many other types of imaging tests that we have, such as bone scan, CT scan, or even MRI. Again, just to carry through with some of the definitions and the acronyms so that we're all on the same page. Everybody's surely heard about PSA, or prostate-specific antigen. PSA and PSMA are 2 distinct proteins. PSA is an androgen-regulated secretory protein that's produced actually by the prostate. And though it's present in small quantities in the serum of men with healthy prostates, elevated PSA is the most commonly used serum marker for prostate cancer. PSMA, on the other hand, is a cell surface membrane-bound protein that's expressed in a number of organs, including the normal prostate, as well as in the kidneys, in the small intestine, in the salivary gland, in some parts of the nervous system. But it is upregulated during tumorigenesis, or growth of cancer cells, with overexpression seen in approximately 95% of all prostate cancer cells. So again, this is what makes it an excellent target for diagnostic imaging with advanced imaging modalities such as PSMA PET. We know that expression of levels of PSMA can increase with the stage of prostate cancer, with the grade, with recurrence, and this makes it a very accurate and, again, reliable tissue biomarker for us.
Thank you for providing that context and helping us with the definitions of PSMA and PSA and what the difference is, because you're right, we have all these acronyms that we're used to, and we just want to make sure everyone's on the same playing field. So how do tell us, how do people know if they're a candidate for a PSMA PET scan?
Yeah, excellent question, and one that's asked all the time. Probably one of the most important questions to ask, regardless of where you are in your prostate cancer journey. So all currently approved PSMA PET diagnostic agents are indicated for imaging of patients with prostate cancer with suspected metastases who are, 1, candidates for initial definitive therapy, And this is mainly to rule out metastatic cancer in those folks that are potentially curable by surgery or radiation therapy. The National Comprehensive Cancer Network, or NCCN guidelines, recommend PSMA PET imaging for evaluation of patients who are diagnosed with intermediate unfavorable risk, high risk, or very high risk prostate cancer in this sort of initial staging population. All currently approved PSMA PET diagnostic agents are also indicated for patients with suspected recurrence based upon an elevated serum PSA level. And this is to detect prostate cancer return in patients who already received surgery or radiotherapy, but now have a rising PSA level. And the results of a PSMA PET scan for these patients may help them and their care teams to decide between whether you can have radiotherapy, what type of radiotherapy, or if you're a candidate for systemic therapy. In addition, professional societies, again, such as the NCCN, recommend PSMA PET imaging for patients who are potential candidates for radioligand therapy with Pluvicto. So that's lutetium-177, which is a radiopharmaceutical treatment that targets PSMA-expressing prostate cancer. And this treatment can be used in patients with prostate cancer that has progressed during treatment with chemotherapy or with novel oral hormone treatments. And we know that treatment with lutetium-177 or Pluvicto is most effective in patients whose prostate cancer has a high level of PSMA expression on a PSMA PET scan. We also know that if a PSMA PET scan shows that a patient's prostate cancer expresses little to no PSMA, that Pluvicto or lutetium-177 treatments usually are not helpful in that setting. So really, again, one of the most important questions to ask, am I a candidate? At what point could I be a candidate? And really, those are kind of the basics upon where we determine whether or not patients would benefit from advanced imaging and see where they bring their treatment.
Thank you. That's helpful. So what are some of the advantages of PSMA PET imaging over conventional imaging for prostate cancer?
Yeah, so I'm going to base this answer historically off of the two pivotal clinical trials that were involved with the approval process for one of the PSMA PET imaging agents called PYLARIFY. The two trials names were Osprey and Condor, so birds of prey. But these help to establish the safety and diagnostic performance of PYLARIFY imaging across the prostate cancer disease continuum. And basically results from Osprey cohort A, which was a specific patient population in that first trial, demonstrated improvement in specificity and positive predictive value of PYLARIFY PET imaging over conventional imaging in men with high-risk prostate cancer. Osprey cohort B, along with Condor, which was the second pivotal trial, studied men with prostate cancer with more advanced disease. And this included biochemical recurrence, hormone-sensitive disease, non-metastatic castrate-resistant, and metastatic castrate-resistant disease. Osprey cohort B demonstrated that the sensitivity of PYLARIFY PET imaging in detecting metastatic lesions in patients with biochemical recurrence and non-informative baseline findings, meaning they had negative imaging before they had their PYLARIFY PET scan. Osprey cohort B and Condor both demonstrated that PYLARIFY had what we call the high correct localization rate, which meant that it's on a patient-specific level detected lesions. It also found that it had a high detection rate, including in patients with low PSA values. And then sort of the last point where the advantages of PSMA PET imaging over conventional imaging was really found based upon the Condor study, was that about 64 patients actually had a change in their intended disease management plans after having their PYLARIFY PET imaging scan. And this was based upon 99% of enrolled patients in the study. I do have to note that we don't have outcomes data for these patients who had changes in intended management, but it really does show, I think, the value of advanced imaging, of PSMA PET imaging in directing patient-specific care. So it's really, again, an advanced over conventional imaging, higher sensitivity, higher specificity, great detection rate. And again, these changes in intended management are really important.
Okay, good. We like more options, so that's great. You mentioned PYLARIFY in some of the clinical trials. Is PYLARIFY a PSMA PET scan?
Yeah, so I have mentioned it here. We'll go a little bit more, I guess, in depth into the actual, what PYLARIFY is. So PYLARIFY is the brand name for a molecule called piflufolastat F18, which is quite a mouthful. This was previously referred to as 18F DCF PYL, or simply and affectionately PYL, during its clinical development. It's actually a small molecule radioactive diagnostic agent that's indicated for PET imaging of PSMA positive lesions. And it consists of a PSMA targeting agent, that's the DCF-PYL portion, which is labeled with a positron emitting isotope, which is fluorine F18 or F18. And once administered, these PYLARIFY molecules circulate in the blood and they bind to the active site on PSMA cell surface protein. And again, as I mentioned before, PSMA is highly overexpressed in most prostate cancer cells, so it makes it an excellent target. And after this molecule, PYLARIFY molecule, binds to the PSMA target, the cell actually internalizes it. So accumulated radio tracer comes into the site of the disease, and it stays there where imaging of that isotope, that F18, is possible, while the unbound PYLARIFY agent clears rapidly from non-target tissues. So the 18F radio-labeled portion facilitates the PET imaging with the PET cameras, and it helps depict both the anatomic location as well as the concentration of disease. And again, this is unique to PSMA PET imaging. It's not just functional imaging, such as other PET scans, and it's not just anatomic imaging, such as a CT scan or an MRI. It gives you a combination of both, which again makes it more accurate, just a really very good, effective diagnostic tool for us. I'll have to just mention a little bit about how the molecules are made. Is actually manufactured on cyclotrons that are located throughout the US. The actual molecule has a half-life of 109 minutes, and this means that the dose is made for the patient on the day that the scan is scheduled, and then it's transported to the imaging center where the patient is. It's either driven or sometimes it's actually flown there, and then the patient is dosed.
Okay, fascinating. Thank you. I didn't realize it was that quick.
Yeah.
How long after the biopsy would PSMA PET or CT be advisable?
Yeah, so this is bringing us to the patients, sort of that first indication, patients who are diagnosed with prostate cancer, and they have suspected metastases. So these are patients with unfavorable, intermediate, high, or very high risk prostate cancer. Really, the studies that were done and the PYLARIFY label subsequently does not have any recommendations regarding the timing for PET CT or PSMA PET CT after prostate biopsy. recommendation, basically based upon the studies that we did have, is that surgery or biopsy could occur anytime between 12 hours and 28 days after a PYLARIFY scan. So it's quite a wide length of time. Unlike, I think that unlike MRI, where if you do a biopsy, there can be some hemorrhage in the prostate that can obscure the results, et cetera. We don't find that same difficulty with PSMA PET imaging. Again, because it's both functional and anatomic, we can overcome that with PSMA. Realistically, what happens clinically is that you have your biopsy, you wait like a week or maybe even longer to get your biopsy results back. You have a discussion with your care team through shared decision making. You decide to go forward with a PSMA PET scan, then you get scheduled for it. So realistically, I think that in a clinical setting, it's probably at least a week, if not more realistically, maybe 2, 3, even 4 weeks after the biopsy that most PSMA PET scans are being done in that setting.
Thank you. When should patients ask their care team about PSMA PET scans and if it's right for them?
Yeah, so again, this hinges upon the indications, and really all of the currently FDA approved agents have similar indications, if not identical indications. And so it's really important to ask, and again, to go through the shared decision-making process with your care team. If you've been diagnosed with intermediate, unfavorable, high, or very high-risk prostate cancer, and you're a candidate for definitive therapy with surgery or radiation, I'd recommend that you discuss PSMA PET with your doctor or care team. Or if you've had treatment for your prostate cancer with surgery or of radiation, and at any point during your prostate cancer journey, you experience a rising PSA, this could include after you've been on systemic therapy, such as ADT and ARPI, immunotherapy, or chemotherapy. And, again, this is PSMA PET is actually used. Another indication is that it's used to determine eligibility for radioligand therapy with agents such as Pluvicto or lutetium-177. And so if you are in a situation where you could be a candidate for radioligand therapy, then it's another, I think this is another circumstance where you need to discuss the possibility of PSMA PET imaging with your care team.
How do patients prepare for a PSMA PET?
Yeah, we'll get right down to the nuts and bolts of this. So PYLARIFY specifically does not have any fasting or exercise requiremand it is recommended that patients should be well hydrated prior to administration of the agent, and that patients should actually continue to drink and void frequently for the first few hours following administration. And this is to reduce radiation exposure. It's really simple. It dilutes the urine. We also recommend that patients void prior to being placed on the PET CT or the PET MRI scanning table, and this is to help eliminate any accumulated radiotracer from the bladder, so we get some really nice visualization right around the prostate bed area. A diuretic is not necessary for image acquisition in order to force diuresis. If you're able to hydrate and void adequately, then no need to do that sort of forced diuresis with medication. Likewise, a catheter is not necessary during image acquisition. There really are no contraindications to having a PYLARIFY PET scan. But I do want to note that about as many as 1/3 of patients that are referred for PSMA PET imaging are reported to concurrently be receiving androgen deprivation therapy, or ADT. And ADT and other therapies that target the androgen pathway, such as androgen receptor agonists, they can result in changes in the uptake of PSMA PET imaging agents. And the effects of these therapies on the performance of PSMA PET has not been completely established. So it is recommended that if you aren't on ADT prior to getting your PSMA PET imaging, that you wait to start that treatment until the scan is performed, as it actually can it can help inform decisions about specific therapy, but also because if you start on ADT and then have the PSMA PET imaging, we're not really sure how that sequence affects the overall results. If you're already on ADT and have a rising PSA, we have found that there is really no change in the sensitivity or specificity of patients who either were on ADT or not on ADT when they underwent their PSMA imaging. So again, no change in those patients, but it's recommended that you don't make some, big adjustments or shifts in your medication as far as those that target the androgen deprivation pathway prior to having the PSMA PET imaging.
Okay. Those are helpful notes. Thank you. So tell it more nuts and bolts here. What happens during the PSMA PET, and are there any side effects?
Yeah, so again, getting a little bit back to the biochemistry here, if I don't bore everybody. As I said, PYLARIFY is radio-labeled with F18, and it's produced on a cyclotron, and it actually decays to stable oxygen 18 with this half-life of a little more than 109 minutes. So it is injected, via IV into the patient, where it rapidly distributes within 60 minutes. And it goes to the kidneys, it goes to the liver, it goes to the lungs, but it also goes to those PSMA rich areas where it's meant to target. There is some normal tissue distribution of PSMA, which includes the lacrimal glands, by the eyes, the salivary glands, the liver, the spleen, as I mentioned, the kidneys. And so the normal organs uptake PYLARIFY, but the impact on that, as far as the actual uptake in the tumor, is very much like non-existent. It's basically nil. So we do see when we inject the patient, what happens during the PSMA PET is that there's sort of this normal, what we call normal biodistribution of the agent. Experienced PSMA PET readers look at the PET scan, the PSMA PET scan, and they see all that normal distribution. And then from that normal biodistribution, they're able to pick out the abnormal places where PSMA PET lesions could indicate metastatic prostate cancer. Again, the agent is given via IV. About 60 minutes afterwards, you're asked to void, you're put onto the table. And then during imaging, you're basically positioned with your on your back with your arms above your head. The image acquisition takes about 12 to 40 minutes, depending on the number of positions that are being taken, et cetera. And the actual scanning goes basically from the mid thigh and goes all the way up to the skull vertex. So it's sort of this whole body minus the very lower legs there. As far as any side effects, PSMA PET imaging is very well tolerated. The most common reported adverse reactions, and this was an incidence, of less than 2% in our pivotal trials, were headache, something called dysgeusia, which is sort of an abnormal or altered kind of metallic taste in the mouth, and fatigue. These reactions were self-limiting. For example, the dysgeusia or the altered taste in the mouth is there for anywhere from like 30 seconds to 3 minutes, and then it goes away. There was one hypersensitivity reaction noted in our trials, and that was a patient who had a history of significant allergic reactions.
Thank you. How often can patients receive a PSMA PET, and at what stage of treatment?
Yeah, another excellent question. Depending on where you are in the prostate cancer journey, there really are no specific timing recommendations for PSMA PET scans. In fact, all of the labels for the approved agents are very broad with regards to the use of imaging of patients with prostate cancer with suspected metastases. Again, who are candidates for initial definitive therapy, and with suspected recurrence based upon elevated serum PSA levels. And so really PSMA PET imaging can be utilized pretty much along the entire prostate cancer patient journey. And so that's from, after, for staging after diagnosis, and then at any time that you have a rising PSA, which can be after definitive therapy, it can be after you've had a salvage therapy, it can be after you've been on systemic therapy, it can be after you've been on chemotherapy. So it really is all the way along that journey that we find utility for PSMA PET imaging.
Okay, that's helpful to know. Thank you. And last, I think we've got here, does an elevated PSA mean that the PSMA PET or CT would be able to detect metastasis?
Yeah, so all the approved product labels for the commercially available agents do not specify a PSA threshold level for imaging patients who meet the indication requirements. Again, going back to one of our pivotal trials, the Condor study, this evaluated the diagnostic performance and clinical impact of PYLARIFY in men with biochemical recurrence of prostate cancer after definitive therapy. And men who had had a radical prostatectomy needed to have a PSA greater than or equal to 0.2 in order to be included in the study. And this was based upon AUA guidelines at that point. Men who had radiation therapy or cryotherapy or even brachytherapy needed to have a PSA greater than or equal to 2 above the nadir, above their specific nadir in their journey in order to be included in the study. And again, this was based upon AstroPhoenix guidelines at that point. And detection rates for PSMA PET imaging agents we do know are affected by and do correlate with these PSA levels. And so what we found in Condor is that the detection rate did rise with increasing PSA levels. And this makes sense. Inherently it makes sense. And what we found that in patients who had a PSA, and these are patients with recurrence, so patients who had a PSA less than 0.5, detection rates were the lowest, which makes sense, 36.2. And that went all the way to a detection rate of 96.7 in patients who had a PSA greater than or equal to 5. And in addition, a retrospective analysis assessed the performance of PYLARIFY in men with biochemical recurrence after radical prostatectomy. And it found that detection rates were 91 for patients with PSA levels over 2, 82 for PSA levels that were 1 to 1.99. And then for PSA levels of 0.5 to 0.9, a little over half. And again, for PSA levels 0.2 to 0.5, it was actually, around the 60% mark. So, I know it's a little bit counterintuitive because we had a higher detection rate at a lower PSA, but in general, the trend speaks the same thing. The higher the PSA, the higher the detection rate as well. But I think the main point is even at very low PSA levels, and we're investigating this more and more, what is the optimal PSA, particularly at time of recurrence. Even at PSA levels of 0.1, as low as 0.1, as low as 0.2, there is utility for PSMA PET imaging. And really what, this hinges upon is that we know based upon evidence that early salvage in those situations does affect outcomes. So it's really important to, I think, really understand what is the lowest PSA level at which PSMA PET imaging could be effective. We're figuring that out, but right now it's not quite elucidated. We do know that we can get quite low, and we do know that detection rates increase as PSA levels increase. So one is intuitive, the other one we still need to elucidate.
Okay, well, thank you so much for that great presentation. We encourage those viewing on Facebook to put any questions they may have, and we can get to those at a later time. But I just want to thank you, Dr. Kuftinec, for providing this information. I know we both want patients to be informed about their options, and this is maybe an exciting new option for some folks watching today. So it gives you and your doctor more information about your prostate cancer, and we hope that you'll have those conversations with your doctor if you listen today and think you're a good candidate for this. So again, Dr. Kuftinec, thank you so much for this, and thanks to everyone joining us today for this viewing.
Yeah, thank you again. I really appreciate the opportunity.